So today we're actually going to be talking about the spinal cord itself. I treat one of many spinal cord diseases, but there are several, and it's actually a pretty broad topic. So we're going to be jumping a little bit all over the place because I wanted to kind of give everyone a large overview. So if there's a specific question that you had that I don't cover, please let me know. We'll do questions at the end. But otherwise, I'm hoping it'll just be very informative to kind of get everyone on the same page. So if we're talking about the spinal cord and diseases, you have to know what it does, right? So what is it? Well, it's essentially a highway. It connects your brain to the rest of your body. So everything that your brain is controlling, your arms, your legs, me talking, you sitting in the chair, vision, everything, it goes through your spinal cord so that it actually connects to the distant sites. And it's essentially a highway. The thing that, that most people are most familiar with is that the signals, that the communications that are sent has to do with your sensory system, how you touch, feel, sense things that are happening in your environment, motor, moving your arms, legs, toes, bowels, bladders, things like that, and then balance and coordination. It's also part of your spinal cord, but it's a process that people actually aren't aware that it's actually your spinal cord plays a large role in. So that's kind of why I wanted to bring that to attention. There are also pain mediators in your spinal cord. And the unique thing about pain mediators is that it actually exists within your spinal cord and it doesn't need input from your brain. So everything else needs input from your brain to connect with the rest of your body. But pain mediators themselves exist in the spinal cord without any input from the brain. So some of the pain symptoms actually are directly spinal cord related. There's also this autonomic system. Do you guys, anyone here knows what the autonomic system is? Or does? Sort of. Exactly. So there's two main systems. There's the sympathetic nervous system and then the parasympathetic nervous system. So the sympathetic nervous system, if you guys remember back to maybe high school physiology, whatever they covered, it's your flee or fight system, right? Do you run away from this giant bear, or do you try to sit there and start fighting it back? So there's that system. So with that, having your heart race, having you sweat, having you run, actually shutting down your bowels and bladders because at the time with the bear, it's not the time to go to the bathroom. So similar things like that. Whereas the parasympathetic system is more of a rest and digest system, right? There's no one immediately attacking you. You're sitting down, you are ready to eat, you're ready to relax. So that's why we call it rest and digest. So that's your parasympathetic system. So it has opposite effects. Sympathetic makes your heart rates faster, pumps your blood, gets you ready to going, everything communicating. Parasympathetic calms everything down, lets you adjust, lets you relax and kind of enjoy the moment. And then there's reflexes and arcs that are through there, and when you come to me or any of my colleagues and we do reflex testing, we're actually testing the pathways in your spinal cord. So where is the spinal cord? You kind of have to know where it is, because if we're going to talk about disorders affecting it, the location is very important. So where it is, it's in your back. We all have it, right? We all have a spine. It's that structure here. I actually went to a conference a few weeks ago and they talked about spinal cord, and this was the exact same picture. So this picture is everywhere and everyone is pretty familiar with that. But if we took a better close-up picture of the bone itself in the spine, what you'll see are three views. So this is it coming in front. This is what your spine looks like. This is what it looks like from the side. You're facing this direction and the back's over here. And this is what it looks like in the back. What you're noticing is that there's lots of vertebrae, right? Those are the small bones. In between them are discs. So whenever you've heard of bulging disc, herniated disc, that's what we're talking about, is the disc spaces between the bones itself. There's two curves to it. So there's a cervical curvature, and then there's a lumbar curvature. And that's kind of as we are babies and we crawl around, you start holding your head up. That's when you start developing the cervical curvature. As you learn how to walk, and then your back straightens up, you get the lumbar curvature. So those are the two normal curves that happens throughout life, and that's actually where probably some of the diseases occur, because those are the ones that start bending as we develop and grow. And then this is just where it looks in the back, so that when you touch your spine and you can feel, these are those little bones in the back that you're feeling and touching. And that's just kind of the overall overview. When we look at the spine itself, we split it into three regions. So the cervical region, the neck, the thoracic region, which is in the middle, the lumbar region in your low back, and then we actually consider the sacral and coccyx region as part of your spine. Those are actually individual bones that became fused together and created a larger bone. So that's kind of the process that we're looking at here. So if we take this and we flip it on its side, what you actually notice is in this space here, that's where your spinal cord lives, okay? So you have to know about your spine to know about your spinal cord, because that's the interplay between diseases and dysfunction and injury that occur. Again, the vertebrae, this is the front view, this is the back view, and as you can see here, the spinal cord sits right in that middle. And what it does is that it sends nerves out from the main spinal cord, and that's how your brain then communicates with your arms and everything else. So what you'll see here is, again, all those vertebrae, and then we're splitting into the different regions of the spinal nerves. So now you have 30 vertebrae, right? 7 cervical, 12 thoracic, 5 lumbar, and then the sacral and coccygeal region, which are combined. And then what you're noticing is then you have nerves. Well, you have 31 paired nerves, one for each side of your body, but only 30 vertebrae. And that's because this one comes out on top. Everything else comes out right underneath the bones. So that's why we look at that. The other thing to kind of note in this picture that's interesting, that becomes relevant to anyone has anyone ever gone a lumbar puncture or has an epidural or something done to them? I think most of the females in this room have had epidurals at least. The unique thing is that your spinal cord comes down, but it ends around the L2 level, right? So your spinal cord ends, and then the rest of this is just nerve roots. That's what we call the cauda equina, essentially meaning the horse's tail, right? So all it is just nerve roots and horse's tail coming down. The nice thing about doing a lumbar puncture and knowing this anatomy is when we do a lumbar puncture, we go down here. So we're not anywhere near your spinal cord, which is why the risk of injury is so low with that. We're not hurting your spinal cord. So when people just come to me and they worry about paralysis, I like to break out this picture and saying, there's no way we can hurt you and cause paralysis because we're so far below. Now, if you have a disease process and your anatomy is different, that's a different story. But for most people, your spinal cord ends here, and then down here is just nerve roots. And just like the horse's tail, just like your tail, if you stick a pen through it, you're not hurting your hair. So when we stick a needle through here, all the nerves just move out of the way, and we're actually not hurting anything. And that way we can actually collect your spinal fluid and get good information about what's actually happening. Or if we need to apply anesthesia, as in the epidural, we're not entering in the space, but should they accidentally go too far, we're not hurting anything. And that's kind of the most important thing to take away from this picture. The other thing is that when we talk about imaging and MRI studies, which we'll talk about in more detail later, it's the easiest to know where we are based on vertebrae level. So when they talk about cervical disc disease, they're talking about cervical levels. When we say you have a spinal cord lesion at the T12 level, we're talking about the vertebrae level. But if you actually notice where the symptoms or where the spinal cord area that correlates to that level is actually in your lumbar region. So those are kind of important things that we talk about. In the disease that I treat, like multiple sclerosis, where it only affects your brain and spinal cord, I actually only look down to the spinal cord, and a lumbar MRI doesn't help because the lumbar MRI doesn't actually look at the spinal cord, it looks at the spinal roots. So there's kind of intricacies there that we kind of, now you guys know and you can share to other people too. If we kind of go back and you look at the spinal cord nerve roots, when we look at the MRI, we talk about where vertebral levels are, but each one of these numbered area segments then goes to a certain place in your body. And just like you have a highway, so like we said, the spinal cord's a highway connecting cities, connecting other things like that, there's only one road to each city or one road to each destination. Your body doesn't want to be confused. It doesn't want to send multiple roads into one city. So this is what we call a dermatome map, okay? Each one of those nerve roots that leaves the spinal cord then goes to a very specific place. So all the ones in the cervical region, we number them because we're simple people. C2, C3, C4, C5, again, just numbering the exact nerve roots and where they go. Your thoracic region innervates this area. Lumbar region innervates down more into your legs. So that's why when we're talking about different diseases, you can have symptoms down in this area, but we know exactly which region we're talking about. And the sacral region is your sex organs, urinary organs, and then the back of your legs. So if you're talking about hand numbness and tingling, that's why we look at your neck. If you come in and you complain about leg problems, that's why we look at your lumbar spine. If you're complaining about problems in your chest or torso, we're looking at your thoracic spine. And we use this map to kind of help us pinpoint where the problem actually is. We're going to switch gears, and now the focus becomes less on the spine and more on the spinal cord itself. So what we did was we took that spine, and now we're flipping on its side. This is the back, this is the front, and in that you see this nice spinal cord. So the spinal cord is separated into very distinct regions. Just like the brain, some of you guys might have heard of gray matter and white matter, the spinal cord is organized in the same way. So you have gray matter on the inside and white matter on the outside. And each one of these areas has very specific fiber tracts, but I just kind of wanted you guys to get an appreciation of the anatomy. The reason, because there's a lot of space around your spinal cord. So you move, you know, we're mobile people, we don't sit still, you move, you bend over, and you need room for your spinal cord to move around. You don't want it to be completely tight. So that's why there's space in there. And then there's nerve roots that come out, and then they form those nerves that we talked about earlier there. And what's interesting out here is once we start talking about disease, such as disc disease, and how it impinges on the spinal cord in the space, that's where knowing where the nerves lie and everything else, that becomes important. A basic overview is the ones that come out of the back is actually your sensory input. So it comes out from your body, it connects in here, and that's where the sensory input, so out from your body up to your brain. And then the motor input, it comes from your brain and then out to your arms. It comes down and it comes out through the front. So other details about that what we're talking about. If we go a little bit closer into that tract, that's what we're talking about here. So both sides are the same, but this is just separated for visual effects. So ascending tracts, information that goes up to your brain, is the sensory stuff that we're talking about. So you have different sensory fibers coming back here. You have different sensory fibers coming up the front here. And then back here is where your cerebellar tract is. So those are the fibers that actually are important in coordination and balance. Over here, we're talking about the main motor tracts. So these are descending tracts. They go down. They're coming from your brain, controlling movement in your arms, legs, fingers, toes. And there are big tracts out here, and there are little tracts out here, but lots of different tracts. So in this tiny little spinal cord, there's so much activity going on, which is why when we're talking about spinal cord injury, and everyone's like, well, what's the symptom? Well, it's so varied. It just depends on what we're injuring. And it depends on what the problem actually is. But if you look at how well tight it is, how tightly condensed it is, how well packed it is, you can just see why people have lots of problems when they have spinal cord injury. But not everyone's problems is the same, because again, it depends on what's being hurt and what is actually being attacked. But that's just the general overview, so you can kind of get an idea, and this becomes more relevant when we actually start talking about diseases. This is another picture of similar tracts that we're talking about. Again, descending pathways are now red, things that go down. The blue is ascending pathways, so sensory systems that go up. And what I wanted to kind of note here is it's actually mapped out in a very specific pattern. So I don't know how many of you guys have heard of the homunculus. So it's actually called a homunculus. It's the little human. If you're talking about your brain, it's actually a map of what a human looks like in your brain. So a very specific part of your brain controls your face, a very specific part of your brain controls your mouth, a very specific part of your brain controls your arms, a very specific place controls your legs. Because again, we're talking about how do we take someone who is so dynamic and control them very specific and purposefully. And it's the same map that exists in your spinal cord, so that areas that control your arms are here, area controls your middle of your body is here, and then area controls that your kind of more the sacral areas, so the sex organs, ends up being kind of more in the middle. And again, same thing out here. So how the motor system is arranged in similar patterns, so that the closest to the middle is actually your arms, and the farthest away is actually the sacral area. But it makes sense. It's not that the cervical region is next to the sacral region. It just makes sense if you're trying to organized wiring. My husband will laugh at me. I'm not sure how many of you guys have wires, but when you have your computer set up at home and you've got the printer wires and the internet wires, I like everything neat and bundled, okay? Some people don't, but your body likes everything neat and bundled. So everything makes sense. It has to go, you know, the nearest wires are connected the most, the farthest wires are on the outside, and that way you don't get a lot of jumble in there. This is a brief overview. This is when we had referred to the autonomic system earlier. And just in case you weren't sure, all of the different systems of the autonomic system, I wanted to bring that up at this point. So your sympathetic nervous system, remember, your flight or fight, dilates your pupils because you need to see who's attacking you. You need to see that bear and you need to take in all that information. You don't want to be salivating, you don't want to be drooling during this time. You want to be able to breathe easier and take rapid, short breaths. Your heartbeat is pumping, again, to get blood flowing everywhere. We're not digesting food, so the last thing to do when you see that bear is to actually eat. And then there's, you know, increase in some of the blood sugar levels, increase in norepinephrine or adrenal organs, relaxing your bladder but contracting the urethra. So when you urinate, your bladder contracts, which is the last thing you want to happen, and then your urethra tightens because you don't want to have, you know, you don't want to focus on going to the bathroom. You want to focus on something else. So that's the sympathetic nervous system, whereas the parasympathetic is the opposite. So everything else does the opposite of what the sympathetic system is. But if you notice where the information is housed in your spinal cord, right? The parasympathetic system is in your brain stem, and then in the sacral region, whereas most of the sympathetic nervous system is actually within your spinal cord itself. Now, this isn't going to be a topic that we focus on at all, but if you guys are read anything about people with spinal cord injury, then they have sometimes a lot of sympathetic dysfunction. And the reason why they have sympathetic dysfunction is because all of their sympathetic innervation is within the spinal cord, and their parasympathetic symptom is actually intact. So that's kind of where they can have different problems with regulating their heart rate, regulating their bowels, regulating their stuff, because this is where that information is held. So if we're going to shift now, we talked about anatomy as a brief overview. There will be no quizzes later, so you don't have to recall any of this information. But what I really wanted to highlight, the only reason why I went through that exercise is because, again, the symptoms depends on where your injury actually is. If it's in the cervical region, then the symptoms are going to be in your arm. If it's going to be in your, if you're going to have leg problems, it's going to be in your lumbar spine. If you're just going to have problems with sensation, and it's just the posterior tracts that we talk about, then it's just a problem of vibration and a problem of balance, but not a problem of muscle strength, and it's not a problem of pain sensation. You can't just have injuries to your pain centers and therefore feeling everything burns, everything hurts, but you can still walk and you can still move and you can still do other things. And again, it just depends on what's being affected. And then the other thing we look at as neurologists, or neurosurgeons, anyone who works with spine, is the pattern of the symptoms. Because there's certain disease processes that have certain patterns that like certain tracts or certain injury. And because we know that, then we know which disease to look for. So we look at both. This is just a picture to let you guys know it's fairly clinical. All medical students look at this. But just so it highlights what we're talking about, again, we're talking about your sensory systems back here, here and here. Your sensation is split into two things. One is vibration, the other is proprioception, which is, do you know where things are in space? Do you know where your hand is relative to the air, relative to the chair, relative to the table? That's proprioception. Versus this other sensory system, which is the pain, which is the light touch, which is the discriminating. Do you know that you have a key in your hand? Those systems are separated in two different areas. And that's what we take advantage of when we take advantage of the anatomy. As you guys are all aware, hopefully, that your brain is separated into two halves. And essentially, the right side of your brain controls the left side of your body. The left side of your brain controls the right side of your body. But where those information crosses difference. So that when we're talking about vibration, that stuff crosses later, whereas your pain information and your motor information kind of crosses right away. So If you take out the entire spinal cord, which is what we're showing here, you lose all modalities below that level. So again, if your injury is just in your lumbar spine, your arms are fine, but you lose everything below that. And that's if you had a complete cord transection. Well, let's say you only had half of your cord transection, right? So gunshot wound, knife wound, something like that, but it only affects half your spinal cord. Well, because of where the fibers cross, your symptoms are actually different on each leg, right? So on one side, you lose all strength, you lose pain sensation, but on the other side, you lose vibration, and you don't lose it on the same side, so then you have different symptoms, again, because of where things cross. And if it doesn't cross right away, then that stays at the same side. And that's what this is just highlighting. So again, we're looking at the anatomy, we're looking at where things run in this highly organized system that explains the symptoms that you have. So people could have an injury here, and in each person it presents slightly differently, again, because of how everything is laid out. Other lesions that are interesting, again, more for people who like to study this kind of stuff. But if you just had a small lesion, remember how I talked about that brain map where your cervical region is versus your lumbar region, which is your sacral. So if you just have a small map, then all you're affecting is your cervical sensation, and it only affects your arms. Whereas once you finally extend out, then you have a bigger symptom, but that your sacral areas are on the very edges of your spinal cord so that your sex organs are still intact. Isn't that fascinating? You can just have different patterns of diseases just depending on what's going on. If it's just affecting the back, then you'll lose vibration and position sense everywhere, but motor is fine. Everything else is intact. If you have just something that affects the beginning of your spinal cord, an anterior cord syndrome, what causes that would be a stroke. You lose some of your motor function, you lose some of your pain and sensory functions, but you still have intact vibration. And again, it just depends on where the pattern. So this is the pattern that I'm talking about, knowing where the problem is. We're going to shift again. So we talked about the anatomy, so you guys understand where the spinal cord is, what it does, what's its purpose. We talked about how the locations matter, that anatomy, that very highly organized structure. So we're going to shift to actually now the diseases. And I think we're going to spend a majority of our time on this. There's lots of diseases. Anything unimaginable can affect the spinal cord. Something that runs from here to here, anything that you can imagine can affect it will affect it. So it's a very broad, very non-detailed about any of these diseases, but I did want to just highlight the diversity of things that could actually affect your spine. So trauma, that's probably what most people are aware of. When you talk about spinal cord injury and spinal cord diseases, I think the thing that comes to the surface of everybody is trauma. So we're talking about people who are fighting in wars, car accidents, victims, other things like that. That fits under trauma. Structural, disc disease, herniated disc, things like that, where there are congenital malformations. Are there other issues that are coming up? Infections, right? There's no reason why a bug wouldn't like your spinal cord over anything else. So it could also have infections of your spinal cord. There's inflammation. This is where I come in. So again, one small disease of a large process that affects other things. But there's different inflammation processes that can happen to your spinal cord. A lot of nutritional deficiencies. So your spinal cord does lots of things. So depending on what vitamin you're missing, it could actually affect the process that's going on in your spinal cord. So there are different nutritional factors when we talk about spinal cord disease. There might be a reason why your doctor checks your vitamin levels. And it's again because of the pattern, because we know that certain deficiencies will have spinal cord implications. Degeneration, so these are other processes that occur and happen in the spinal cord. That's probably something that people don't know as much about, but we'll highlight that when we talk about those processes. And then tumors. Tumors are always there in any organ system that you talk about, and the spinal cord is not unique. The last place is vascular, so we're talking about strokes, we're talking about venous malformations, other bleeding injuries, and these are the variety of everything that could possibly go wrong in your spinal cord. So trauma, slip and you fall, you hurt yourself. Most common one, everybody knows about Christopher Reeve and that injury that he has. And that's essentially all I'll talk about with that. But if you have a trauma, depending on if it's a high trauma cervical area, if it's a low trauma, and how much is actually injured, that's where the symptoms you'll have and where the treatment and where the focus is going to be. It depends on that process as well. There will be something I will talk about initially. So when you have an initial trauma and an acute trauma, there is this phenomenon called spinal shock. So what that essentially means is that your entire spine has no idea what just happened to it. You know, you injure it, you just fall suddenly, your entire body goes numb. Well, it's not like you injured your entire spinal cord, but essentially it feels that way because your spine is actually just shocked. It's not sure what's happening. And then as the shock goes away, then the actual place of where your injury occurs, those are the only symptoms you have. So that's kind of that spinal shock, and that's the only part of the trauma that I'll bring up, because when someone initially presents to us and they're entire numb, we kind of wait a couple days or wait a couple hours to actually see where their injury occurs. The structural, so this is the degenerative disc disease is the most common. So if we look at that, what we're talking about here, so this is an MRI picture. These are the bones that we talked about, so that's your vertebrae. Between the bones are your discs. And then back here is the spinal cord space. Now we're looking at the spine, the lumbar region, so you actually won't see the spinal cord in there, you'll just see the nerve roots. But this is what a normal disc looks like. It's got a nice color, it's between the bones, and it does nothing to impinge on that space, that circle that we talked about here. Whereas when you have a bulging disc, it kind of starts sticking out into that region. And when it's herniated, it's stuck out so much that it's actually probably hurting something. So that's the difference between, do you have bulging disc disease that we don't do anything about, versus do you actually have a herniated disc that is now causing problems and needs intervention. This we watch. This can respond to physical therapy. This, depending on how far it is, might actually need surgical correction. And these are the different things that can go wrong. So again, we talked about the bones and we talked about the normal disc. The disc, all it is cartilage. If you have a bunch of bones and they're sitting right on top of each other, you can imagine hard surfaces rub against each other, so your body gives it a little bit of cushion. It also, the cushion allows you to bend over, turn side to side, and do other things. So as we turn side to side and do other things, we lift heavy objects, then you might actually have injury to those discs, and then they can cause bulging disc disease, which is why, as physicians, we really bug our patients about, are you using proper body mechanics? Are you wearing that belt when you lift things? There's a reason why we want you to protect yourself rather than just bending over pick things, because we know how sensitive this region is. Within that cartilage can do different things. So it can just cause a little bulge, where you see that canal might still be intact, it might not actually injure anything. If it goes a little bit further, then it's actually impinging on that nerve root as it comes out. So instead of actually hurting everything below your entire spinal cord, it's actually impinging on just one of the nerve roots. So you might just have pain in one side of your body, just shooting down a very specific pattern. Or did it kind of come out all the way and now it's causing other problems? But that's essentially what it looks like, and that's what we're looking for in MRI, and that's what we're talking about when we talk about disc disease. There's a couple of other things to know. So other structural processes, one of them is called a syringomyelia. So if you actually look at your spinal cord itself, and I didn't have a picture on this, but in the middle of it, your spinal cord, your brain gets nutrients from the spinal fluid. Well, the spinal fluid needs a way to travel. So it travels one around your spinal cord, and then in the very middle of your spinal cord, there's a small hole where the spinal fluid also exists. If that hole gets bigger, then we can have a process called syringomyelia. And again, because some of those fibers are in the middle, if that hole expands enough, then it can start hurting some different things. So this is a rare process. Certain people have it. Sometimes we monitor it. Sometimes we need to intervene, again, depending on whether or not people actually have symptoms from it. There are some congenital processes that are going. So people with spina bifida, there's tethered cord, there's a whole host of diseases that are structural due to malformation, different medications. So there's a reason why we are very careful with pregnant women and the medications, because one of the medications can lead to malformations of the spine, which then doesn't protect the spinal cord and it doesn't develop properly. So that's why we're very cognizant about the drugs that a pregnant woman takes. Infections. So a whole lot of things can affect your spinal cord. What I deal with probably most commonly is a viral myelitis. So somebody comes in, they have the flu, they have some unknown virus, and then now that they have trouble moving, walking, or something because now the virus has also infected their spinal cord. HTLV is human tropical lymphocytic virus. It causes a disease called tropical paraparesis. Unless you deal with it commonly, we won't really talk about it much else, but this is another virus that affects it. Syphilis is an old one. It's the one that we've actually probably known about more 100 years ago than we know about now, because I think the cases are much decreased. If you don't treat syphilis early on, like they did in the 1800s, they didn't treat it early on, they didn't recognize it at that time, then eventually you can actually have spinal cord injury because that virus or that bacteria likes the spinal cord. So it actually just goes there and then it causes disease later in life. So sometimes when people in our older patients who might have had a more fun history, a fun time in their life, if sometimes they present with some weakness or some things in a pattern that we are concerned about this process, we'll actually check them for syphilis. HIV and AIDS also likes the spinal cord, so those patients can have a lot of spinal cord injury due to their disease. Meningitis, so around your spinal cord in your brain, there's a lining that protects it. Those are called your meninges. And if there is an infection of that, that can also occur in your spinal cord. Abscesses are collections of infections. So instead of the bacteria going everywhere, it collects in a very specific place, and then it can cause more of a mass effect, so a compression-like process. Tuberculosis is also something that can affect your spinal cord. There's different parasites or bugs that can affect your spinal cord. So this is what an abscess looks like. So the abscess isn't an infection of the spinal cord itself. It's an infection near either of the disc or the bone. It's causing a mass effect. It's a collection of fluid, pus, things like that. And that itself is what impinges on the spinal cord. So that's a process that can also lead to what we're talking about here. And so this is a bone infection with an abscess that's causing spinal cord impression. That's what we're looking at here. These are the non-infectious inflammatory disorders. So when we talk about inflammation, it is usually due to infection. Sometimes it's just due to other inflammatory processes, other autoimmune diseases. So this is the one that in my practice I come along a lot. The most common is what we call a transverse myelitis. All that means is infection of or inflammation of the spinal cord. So it's very simple. It's a fancy word, but it really means simple things. It can happen post-infectious, para-infectious. So not that the virus actually infected your spinal cord itself, but now the virus has triggered an inflammatory process, and that inflammatory process is what affects your spinal cord. Multiple sclerosis is an inflammatory process that affects the spinal cord. And with that, a similar demyelinating autoimmune disease, but is separate from multiple sclerosis, what we call neuromyelitis optica, again, because it affects the spinal cord, that's what myelitis means, and the optic nerves. That process is also something that I come and see because of this. Other diseases, so sarcoidosis, which is a primarily lung problem, but if it affects your nervous system, it can have a preference for the spinal cord. Lupus can also affect your spinal cord. And then we call paraneoplastic syndromes. What this is that you have a cancer somewhere else, but what the cancer has done to your body is to create an inflammatory process, and that inflammatory process then goes on and attacks your spinal cord. So just some pictures here. This is a patient with MS, so you can see the MS lesions. They're small and they're short. It might be hard to see, but you're looking at the thoracic spine here, and what helps us is the numbers, right? So it's got T in front of it, that means thoracic. So the numbers tell us that you have a lesion here, and that's what I was talking about earlier. So we base it on the level. So this is the T1 level, so we say you have a T1 lesion. That doesn't mean your symptoms are necessarily there. It just means that that's how we identify where it is. Like I said, down and around T9 or T10, that's where your lumbar levels are, or your lumbar innervation is. But it's in your thoracic area. So it's just kind of one of those little things. If you ever question why your doctor's looking there when it's something, it's because of this anatomy. This is what sarcoid looks like in the spinal cord. So a bunch of small dots throughout. So it looks very different from this disease process. It also looks different from this disease process. So this is someone with a para-infectious transverse myelitis. They actually had the flu-like symptoms and then became paralyzed, and the reason why is when we took a look at their cervical spine, they had this long lesion. And again, when you have a long lesion, you can imagine that everything below their cervical spine is affected. But this actually heals, and it gets better. We just have to watch it. This is the metabolic toxic myelopathies. I kind of lumped all these in together because it's rare. It just depends on if you have it. In and of itself might not be singly interesting. But when we're talking about the nutritional deficiencies, so a B12 deficiency prefers to, B12 is important in your spinal cord. So a lot of people have weakness or trouble just because having low B12 levels. With that, copper deficiencies can do that. The most common cause of copper deficiency, do you guys know? Denture cream. So denture cream actually takes copper, chelates it or whatever, and it actually absorbs it. So sometimes people with copper deficiencies, we ask them if they wear dentures or use dentures, so they have that. The other thing is using zinc. So people who take lots of zinc supplements because they're afraid of getting colds, that also affects copper levels. So that's one of the reasons why I don't always, I actually recommend against zinc supplements when my patients ask me, but if you do too much of it, you can actually cause a copper deficiency. Radiation myelopathy, say you have a tumor, breast tumor or some type of bladder tumor, sometimes they give you radiation and that can sometimes hurt your spinal cord later. Decompression sickness, do you guys know what that is? Right, scuba diving. So people who go scuba diving, they come back up. For whatever reason, that process of coming up too quickly and the change in oxygen and everything else causes a injury to your spinal cord because of the change in pressure. So this is B12 deficiency. This is what it looks like. The thing to notice about here when I talk about patterns and everything else like that, it actually likes the back of your spinal cord, the posterior region of your spinal cord, which is what you see here. So the back of your spinal cord. So when someone comes to me and they talk about numbness and tingling and proprioception and I check and I do their exam and they can't sense vibration, I would actually be worried about this process. And that's why the pattern of your symptoms and what you have and knowing what diseases typically affect which areas of your spinal cord helps. So that's why in those patients we'll check a B12 level because we know that that's where it commonly attacks. Degenerative processes, so these are the rare things that people don't always think about affecting the spinal cord, but they do. You guys know who this is? Right, Lou Gehrig's, ALS. This is an old movie. I actually have never seen it. I've meant to, but Lorenzo's oil. It's about adrenal leukodystrophy. In kids, it doesn't always affect the spinal cord. It tends to affect their brains. But when adults get adrenal leukodystrophy, they actually have a more common spinal cord presentation. So that's one of the things to be aware of. Spinal muscular atrophy is also a devastating neurodegenerative disorder. It actually is a process that mostly affects kids, but it is one of the things to talk about. ALS we talked about. There's other degenerative diseases. There's spinal cerebellar ataxias. There's Friedreich's ataxia, hereditary spastic paraplegia, other disease process. These are neurodegenerative. It's the spinal cord and the neurons in the spinal cord dying over time, being injured over time in a very slow degenerative process. So this is also affecting the spinal cord. But when people think about it, they don't always think about the spinal cord and they don't always lump it into spinal cord injury because there's other things happening. So spinal cord tumors. As we talked about here, this is your spinal cord. Every cell can cause a possible potential target for tumors. So you can have tumors that are primarily from the bone. You can have tumors from the meninges around there. You can have tumors within the spinal cord itself. You can have processes that happen in this space. But anywhere that a cell can multiply and grow, which is essentially what a tumor is, then it can also happen in the spinal cord. And depending on where it's growing, depends on the symptoms. So if it's in the front, what kind of compression it's causing. If it's on the side, what kind of compression it's causing. If it's within the spinal cord, what level is it, what the problem is there. So this is an example of what a spinal cord tumor can look like. This is just one of them. This is the intramedullary time. So the spinal cord, the tumor originates from the spinal cord itself. But we can look at it. We heavily rely on MRIs because that's our tool to look at what's actually happening there. And we can see all sorts of processes. Vascular events, uncommon but can occur, are strokes. This actually kind of happens commonly when people undergo surgeries for other things. So they'll undergo cardiac surgery, they'll undergo abdominal surgery, and during that process, the blood supply to their spine might be compromised, and then they can develop a spinal cord stroke from that. Other vascular malformations, it can occur in your brain, it can also occur in your spine. The most common is what we call an AVM, arteriovenous malformation. There are other just primarily vascular malformations, that's not an AVM. And then the epidural hematoma kind of fits under vascular, kind of fits under more trauma, but essentially, you know, they go in and instead of, so like I said, it doesn't hurt your spinal cord, it doesn't hit your nerves, but if they hit a blood vessel and it causes blood, that's a different process, all right? But that's the epidural hematoma there. This is a picture of what an AVM looks like. So the normal communication between your arteries and your veins flows through capillary beds, and for whatever reason, instead of going through that, it becomes like this jangled mess, and there's just lots of blood there. And we can see it here. So normal spinal cord is this white spot, and what you see here is a lot of dark squiggly lines. Those are all those blood vessels that are clumping together in there. But it's just kind of a nice picture. Again, how do we diagnose you? You know, you come to me, you've got trouble walking, you've got some numbness and tingling. Well, I need to figure out, is it actually your spinal cord? Is it some other process? So we base it off of your symptoms. Did you have an injury? Does the symptoms make sense? So let's say you hurt your lower back, but now you can't move your arm. Well, that doesn't add up. I actually need to find out what's actually happening to your arm. So then actually looking there as well. So that's kind of where the pattern of symptoms, does it match the type of injury that you've had? Does it make sense? And if it doesn't make sense, we got to keep looking. We heavily rely on MRIs because that gives us a very clear picture of the anatomy, what's going on there, and it helps us very much. There are some things that don't show up on MRI, and that's when we might need additional studies. So has anyone ever had an EMG or a nerve conduction study test? It's not the most pleasant procedure, but it helps us know where your problems are. And with that, we can link, so let's say you have a bulging disc, and we're not sure if it's causing enough injury that warrants surgery. So sometimes we'll do an EMG so that we can map out how much that nerve is being injured by that disc. And if there's no injury, we might recommend against surgery. And if there's significant injury, then we say you might want to go undergo that procedure quickly. But we use these tools all in conjunction with each other so that we can help. If it's a tumor, we do a biopsy. We very rarely try to biopsy the spinal cord because it's such a small, compact structure. If you manipulate it, you might actually cause other injury, but if we're talking about a tumor, it's important to know what it is. So we do biopsies in certain cases. And lumbar puncture, so that helps us know what's actually happening in there too. It's something we use commonly when we're looking at infections or inflammatory processes. Again, some of these are simple, some of them aren't as straightforward, and we use all the tools we can. Treatment depends on the disease, right? So the treatment for someone with trauma is different for someone from a herniated disc, from an inflammatory process, from an infection. So we kind of go through that process. What caused it? What caused the injury? How can we help it? So trauma has its own special circumstances. If it's a structural process, if it's congenital, structural, you know, if it's spina bifida, they can do surgical correction. If it's a tethered cord, we can do surgical correction. If it's an infection, we can do antibiotics depending on the infection. If it's inflammatory, like transverse myelitis or multiple sclerosis, we treat it with anti-inflammatory agents. If it's nutrition, if it's just a simple B12 deficiency, we give you more B12. If it's a degenerative process, unfortunately, we don't really have therapies targeted towards most of those processes. Tumors or surgery, vascular, like an AVM, we can go in right away and fix that problem. A stroke, unfortunately, is not correctable. So it kind of just depends on what we have. I did want to take a time to show you this video. It's actually pretty interesting. Hopefully it works. Oh, no. Okay. Okay. So apparently I'm not connected to the internet. Okay. What the video shows is one of the cool things that we're doing for spinal cord injury patients. It's an exoskeleton. So I don't know, how many of you guys watched the World Cup? Did you guys pay attention? There was a big fuss about this person who was paraplegic, and they were going to use their exoskeleton and stand up and do that first kick of the World Cup. And essentially it was someone who had a spinal cord injury, was paralyzed from the waist down, and they have new exoskeleton devices, which is a way to help people who are paraplegic from injury and other things, how to help them function and get back into life. And it's actually a really cool process. But essentially it's a lot of collaboration between neurologists, neurosurgeons, biomedical engineering, and people who do robotics and other things like that. And it's actually pretty fascinating. The Christopher Reeve Foundation does a lot with them as well to kind of help develop exoskeletons. If you guys go to our physical therapy out here, we do smaller, so it's not the big, bulky exoskeletons that we do, but we have smaller devices that help. So we have hip flexion devices, things that help stimulate your muscle to lift up your leg. We have braces. Sometimes it's the simplest intervention that helps. So if you can't move your foot from a spinal cord injury, just bracing it so that you're no longer tripping and falling is actually a big deal. There's walk aid device. So those are all the stimulation devices. There's all the exoskeletons that they do. A TENS unit is a very simple, but the idea is to help those signals get sent. And that's the process that we have here.
Sorry.
What are you trying to do?
I'm trying to get the full screen. Sorry.
Oh. All right. That's all I have. Okay. Yes?
I have two questions. One, hyperbaric oxygen, because I know in the 70s I was working with a clinic and they were using hyperbaric oxygen for multiple sclerosis, et cetera. Mm-hmm. And the second is an inversion machine. How does that help to stretch the spinal column?
So the first question is hyperbaric oxygen in MS treatment. There's a reason they're no longer using it. And essentially it hasn't really been shown to help. I don't really quite understand what the theory of it, the basis of it is. I think it's great for things that depend on oxygen. So when you're talking about infections, when you're talking about burns, hyperbaric oxygen is fantastic. When you're talking about MS, which isn't really related to oxygenation, the science doesn't quite make sense to me, but it would probably occurred in a time period when we didn't understand as much as we had MS, so we tried everything.
Early 70s.
Yes, we tried everything, and I gave a history of MS talk a while ago. We did crazy things to patients, mainly because we didn't know. So I think that's where the advent of the MRI helped significantly, because once we can see it, we can actually do other things. But yeah, and your second question, can you?
Was the inversion, when you put your feet in and go upside down, the inversion machine in order to, those bulging discs and crushed discs, if you do anti-gravity and kind of stretch them out a little bit.
Oh, okay. So the question was inversion treatment for bulging disc disease and other things. Essentially, you suspend the person from I guess their ankles down, yeah, and doing this. There's other things too that are similar. They're called traction. So if you go to a physical therapist, they might do that, and what it is it stretches out your spinal neck. So sometimes they'll have, the devices look out of like the 1800s, but they work. Essentially, when I was talking about that cartilage that kind of sticks out, there is some idea that there's laxity to that. So you have muscles around your spine, and those muscles need to be strengthened, straightened out. Sometimes if you stretch it out a little bit, you relieve that pressure, and it helps in that sense. So I can't speak to the actual inversion, but it's a similar idea from the traction, is that if you stretch it out, you can kind of get the muscles to relax. You relieve pressure on those nerves. And like I said, it's called the cauda equina. It's called the nerves for a reason. It's mobile, right? So it's hair. It moves around. So if you stretch it out and it's just being pinched on a corner, if you stretch it out, you give it room to move, maybe the symptoms go away because now it's moved. It's no longer touching that area that's injured. Okay? Yes?
when a veteran gets a prosthesis, what do they tap into to make that electrical system work? Good.
So the question is a prosthesis for veterans. What are you referring to specifically? So like if their arm...
Do they just tap back into the spinal cord, or they have to go up to the brain and tap in? Or
Okay.
how do they make it actually work?
So it depends on the prosthesis that you're talking about. Most prosthesis, the general way to think about it is, say you have, your arm is completely amputated. It's most of the older prosthetics actually don't, have any mobility to it. They're just attaching on, and it's just a placeholder, shall we say. So sometimes when people walk, when the leg prosthetics, what they're taking advantage of is their leg muscles, which are still intact. And then they put a hinge on the lower prosthetic so that if you lift up your leg and it just hinges, it takes advantage of the normal bio. So every single time I lift up my leg, my knee bends. And if it's on a hinge and I lift up my leg with the muscles that are there, the hinge moves and I can do that to walk. There are more robotics and other things that they're looking into. And what that is then if you actually connect to the nerve endings, other things, does that work? One of the more, sometimes they can attach it to the muscles that are already there. And then you still have the muscle control. So then you're remapping the system. The only thing that actually taps into your brain itself isn't out of research. And that's where you talk about when you guys see the studies on Nova or Discovery Channel and things, and they have those monkeys that are hooked up to electrodes and they can control things across the room. We're talking about robotics. And what we're talking about is taking advantage of brain waves that we know is there. And if you think about something and you then can control it, and you can train the computer to know that every single time this pattern of thinking occurs, this is what the person's trying to do, they can try to do that. It's nowhere close to anything I think that's available with the veterans unless we're talking about a research lab. But what they're hoping to do is take advantage of the brain connections that are still there. It's just the connection at the distal site that's gone. Okay, so we're using existing wiring rather than creating new wiring. And seeing what other adaptations we can do with that. All right, any other questions? Elko, Pahrump, Tonopah? Any questions?
Oh, I have a question.
Okay.
No questions in Tonopah, thank you.
Okay.
If you have damage to the facet joints, do you know anything, cervical facet joint, obviously, and if you have damage on that side, can it affect numbness or create numbness on the opposite side of, say, your hands and arm? The opposite side of your body, and is there any new innovations in repairing facet joints?
Okay, so the first question is injury to facet joints, would it cause, what symptoms would it cause? Let me get back to, let's see if this slide is still available. So the facet joint is this joint here that we're talking about. So I talked about the main vertebral body, and then I talked about the spinal process in the back. I kind of glossed over the side stuff, but essentially what the facet joints is you've got one disc this way, and you've got a disc underneath it, and it's that horizontal component that's connecting each other. So just like you have other joints, it's just another joint. So it's a connection between the bone up here and the bone down there. So if you have an injury to that facet joint, what you're noticing is what comes out of that is nerve roots. So nerve roots can be injured because, so if you have facet, like arthritis of the facet joints, and then you've got bone that's kind of growing there, that bone can then impinge on that nerve root. But it's not going to cause injury on the other side. So it's only going to cause injury on the side that's there. Now if you have facet injury on one side, you probably also have facet injury on the other side. But that facet injury itself on this side is only going to cause symptoms on that side. In terms of what they're doing new for it, I think that's more reserved for the people who actually go into surgery and do other things. But it's they can do they just clean out the bones to kind of relieve that pressure? Do they replace the whole disc to correct that injury? It kind of just depends on what the actual problem is.
Okay, so you're a neurologist, not
right?
neurosurgeon.
Not neurosurgeon. Yes, I do. I do not cut. So, any other questions? Yeah. Yes.
When arthritis enters the picture, how does it affect the spinal cord or any other part?
So arthritis is just degenerative disc disease. It's a very generic term. Do I have it here? This is kind of what we're talking about with arthritis and we're talking about disc disease. So if we use a common example, like osteoarthritis of the knee, right? What you have is two bones, and in it you have a disc. So most of the time, the disc, or the cartilage, joints allow your bones to bend and move and do other things. It's the same thing in your spinal column, your spine, the bony structures, is that the disc is there and the bones are kind of cushioning against each other. When the disc wears away, as in arthritis, then what you have is bone on bone. And when you have bone on bone, you have changes that occur with that, some inflammation, you have pain, you have other things. And most people understand it when it comes to the knees. Well, your spine is not any different than any other joint. So it's the same thing. So instead of having bone, cushion, bone, you're now having bone on bone. And when that rubs against each other, it causes inflammation. And that inflammation will then lead to discs that bulge and other things.
With the hands.
Right. So it's what arthritis essentially is breakdown of the joint spaces so that bone is now rubbing on bone.
One question here.
Oh,
Did you have a question?
Yeah.
question in, is it Tonopah?
Will that cause the actual...
We're good.
Okay.
We're good. Tonopah's good.
Will
Okay.
that cause bone, the actual bone to protrude at all? If the disc is out bulging to a certain, will they actually feel the bone displaced by that?
So the question is if you have a bulging disc, can you feel bone being displaced?
Well, yeah, like a ridge in your back.
No, you don't. So if I go back to where this picture is early on, this is your back. When you're kind of looking at someone's back, what you're feeling is you're feeling the bumps back here. The disc is in the front. Okay, so if you go through your abdomen and you keep on going back, you'll hit the front of the spine. Then you'll hit the discs. Then that space behind it is the spinal cord. And then behind it are those bumpy things. So in short, you can't feel it because it's so far back.
The spinous process.
Right. Yeah, you're gonna bump into the spine before you bump into the disc. So, yes.
You were talking about the traction, so it would open up the spinal area. Would that give any of that juice a chance to grow back in, or to go back in, or where does that juice come from to go in there? The synovial fluid.
Oh,
If you're using the traction,
yes.
wouldn't the synovial fluid be able to go back in there, or how does that move?
So the question is when traction and how that works and the impact on synovial fluid. So synovial fluid is the fluid that helps your joints become lubricated, right? It's produced through its own cells. So the cells within the joints itself will produce the synovial fluid. That's why sometimes when you have inflammation of your joints, you have excess synovial fluid, sometimes they drain it. A bulging disc is a separate process. So when you're talking about cartilage in your disc, you've got a circle like this, that's essentially a disc, and around it is kind of more like a fiber or something that kind of holds it together. And there's breakdown in that fiber, so then the disc bulges out because it's this pliable, putty-like substance, and it's being held together by things around it. But if you have a break in it, then it can move out and it can bulge in. If you're doing traction, I can't imagine that it'll actually just help push it back in. What you're actually doing is probably just relieving pressure. If you help relieve pressure on the muscles, you can do that. But it's such a tight structure and it's such a small process. I don't know that you can ever stretch it enough, because not only do you have to stretch it, but you have to shove it back in or something like that. So I don't know that that process actually happens with traction.
It would relieve some pain because it's relieving some pressure.
Right. But it's not going to have, it's a separate process than synovial fluid. It's a separate process than actually fixing the structure of the disc itself.
It doesn't repair it, but it
Right.
can release some.
Right. And part of what we do, and sometimes when it's just a small bulging disc, is that we strengthen your muscles. So that's why we send you to physical therapy. When you strengthen the muscles that surrounds it, then that support gets stronger so that the disc doesn't bulge. And sometimes strengthening that muscle allows that bulge to kind of not be as prominent, and then again relieves pressure. So in that same sense, we can talk about that, but I think the idea that you can just stretch it out enough and have it pop back into place is
Just
probably
release the
unlikely.
pressure,
Yeah.
yes.
All right, yes?
Does coffee interfere with B12?
Not that I'm, so the question is coffee interferes with B12. Not that I'm aware of.
Coffee?
Yeah. So the question is bulging discs, what happens if you don't do any intervention such as surgery? Actually, so surgery is successful in maybe only like 20 to 30% of the cases. So it depends on what your outcome is. If you actually talk to the neurosurgeons, and the only reason why I know is because I had this discussion because my mom had some bulging disc and I was very critical of the procedure. But essentially they said it depends on what your goal is. If you're expecting to completely have lack of absence of pain, it might be unrealistic. A more reasonable goal is, let's say you have pain and it interferes with your activities 80% of the time, and now we decrease that pain to only 20% of the time. You're still going to have pain, but that's a lot more function that you have. You can do more because the pain is significantly decreased. If you have weakness or other things, yeah, we should go in and fix that, because that's something that will get better with physical therapy, but you have to relieve the pressure that's there before we can do that. That's where the EMG comes in. And when I had alluded to how much injury is there, well, the bulging disc is causing a little bit of pain, but it's not causing weakness, to the point where you start needing a cane or a walker. Then we might not want to do anything, but we want to see the health of the nerves. And if the nerves are fine, we might not want to do anything. But if the actually nerve shows injury, then we actually should go in, because we don't want to get further damage and further injury. Now, when we're talking about pain itself, pain is one of those things that is just so hard to treat. When you look at studies on disc disease and bulging disc and pain with that, where we're actually most successful is with physical therapy in terms of reducing pain and reducing disability. So if we notice that you have some bulging disc, your only symptom is pain, EMG is completely normal, there's no nerve injury yet, then we actually try physical therapy first, because what physical therapy says is, like I said, it strengthens the muscles that's helping your spinal column stay in place, and sometimes strengthening a muscle does correct and relieve some of that pressure, and that's where the pain goes away, because you're relieving pressure on those nerves and you're relieving pressure on those other things. When they do surgery, what they're doing is then they're also relieving pressure. So sometimes they remove the discs and they put some spacers in there. Sometimes they just open up the back. And when they open up the back, you're also relieving space. So some people ask, well, don't you need those bones back there? And it kind of just depends on how many they're removing and everything else, but sometimes they just remove those bones so that you're having more space in there. So it kind of just depends on what the goal of therapy and what the hope of it is. But if you've tried everything else and you've tried physical therapy and you've tried all these other things, it might be worth it then to do this, because it's the last thing left. And you might get improvement. It's just if you're expecting 100% improvement, it might not be as reasonable goal as improving, something more like 20%. It just depends on how much that 20% affects you, and it's different for everybody. Okay.
I have one last question. What's the new latest, greatest for the MS treatment? You said you're doing clinical trials?
Oh, so we're doing clinical trials. We've got a couple. So the question is, what clinical trials do we currently have for MS, and what's the latest and greatest? The latest and greatest is actually probably what I would consider remyelination strategies. I don't know how familiar, this isn't a talk focused specifically on MS, so if the responses might cover something you don't know, we can talk about it more later. But in essence, MS is a disease where you have demyelination, and one of the strategies is to help your body repair through remyelination. And those are probably the latest and greatest. Those trials are actually closed to enrollment. They weren't looking for that many people, and it's only in phase 2 trials, which if you talk about drug trials itself, phase 1 is the initial concept, phase 2 is to prove that you have enough evidence that you can go on to a large phase 3 studies, and phase 3 studies are actually what most patients can enter. And phase 3 studies are large, multi-center, large trials. You're getting, hundreds of patients, whereas phase 2 studies, you're only looking for maybe one or 200. Phase 3, you're looking for thousands, hundreds and thousands of patients. So that's where the opportunity to enter in is that. Once that becomes available, once that enters phase 3, we hope to be a site. The current clinical trial we have right now is more for looking at the current therapies we have, looking at a different dose that's available. And then we want to focus more on progressive clinical trials. So people with progressive MS and whether or not the treatments we can offer in them have any robust effect.
Now, is this stem cell, or how do you regenerate myelin? Isn't that, it dies, doesn't it?
So the question is, how do you regenerate myelin? No. So the question, it's not stem cells. It doesn't just die. You have, so your myelin's created by what we call oligodendrocytes, which is just the cells that create myelin. In your body, you have baby oligodendrocytes, and they're just sitting there, and they're waiting. And they're waiting to remyelinate, because your body constantly goes through a renewal process. So sometimes it, repairs itself, it gets anew, and that process happens constantly. In inflammation, in something like MS, you have other signals happening that seems to interfere with the ability of that baby oligodendrocyte to actually become a full developed oligodendrocyte. And the remyelination strategies are signaling to help that process happen. So it's a natural process. We're looking at the signaling mechanisms that help promote that process. So that's how that works. All right? Thanks.
Thank you, Dr. Ruvo.